Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare. On today's minisode, Katie McIntyre interviews Dr. Feroz Osmani, an anesthesiologist and interventional pain medicine physician in Central Austin, Texas, USA, speaking from his perspective as an exiting pain fellow. He grew up outside of Chicago, Illinois, and received his Doctor of Medicine degree from the University of Illinois College of Medicine. He then completed his residency training in anesthesiology at the Econ School of Medicine at Mount Sinai Hospital in New York City. After discovering a passion in the evaluation and treatment of complex pain syndromes during his residency, Dr. Osmani went on to further specialize at the University of Chicago Multidisciplinary Interventional Pain Fellowship and was the recipient of the American Academy of Pain Medicine Fellowship Excellence Award. Dr. Osmani takes on a holistic approach for the care of each patient, with the goal of developing a long-term relationship and strategy to regain function, and most importantly to him, to improve the overall happiness of his patients. He recognizes that pain as a person experiences it is not only related to injury, but also an imbalance in the mind and body's fight or flight response. This sensation is a consequence of chronic conditioning of the nervous system to react in a certain way, he proposes. By utilizing a variety of interventional techniques and multidisciplinary therapies, Dr. Osmani is able to re-engineer the nervous system to operate the way it had been intended. He has been published in a number of medical journals, and his work has been presented at various national conventions. His interests include centralized pain syndromes, complex regional pain syndromes, post-surgical pain, chronic abdominal and pelvic pain, long COVID syndrome, and non-operative arthritic care. Dr. Osmani has extensive training in neuromodulation, using peripheral and spinal cord stimulation, minimally invasive lumbar decompression, interspinous spacer implantation, vertebral augmentation, targeted drug delivery, radiofrequency nerve ablation, and peripheral and sympathetic nerve blocks. And with that, I'm pleased to extend a welcome to our interviewer, Katie McIntyre, and an extra warm welcome to the show to our guest today, Dr. Feroz Osmani. How do you learn about neuromodulation?
Learned about it during residency. I went to anesthesia trained. During our pain rotations, we learned all facets of pain, one of which being neuromodulation, big component. And that was just like scratching the surface. So it was when I started fellowship when I really got a deep dive into neuromodulation.
And what has interested you in neuromodulation?
The idea that patients that come in with a variety of pain complaints, their experiences with pain, the reasons why they're having pain, it can be changed. I mean, they're conditioned to feel a certain way due to a variety of different reasons, experiences, biopsychosocial reasons. But at the cellular level, it's nerves that are transmitting these signals, and it's neuromodulation that kind of change those pain pathways so they can, they've seen it, they feel better.
Yeah. What is the best spinal cord stimulation patient outcome that you've witnessed during your fellowship?
I mean, all of our patients have done really, really well. I think we select patients pretty well here. We definitely don't throw that, stims in every single patient that comes our way. As long as in a correctly selected patients they're motivated to feel better, they want to feel better, they have goals of where they want to reach, and they're just not there, and something's holding them back. And there's a reason why they're feeling the way they are, and it's some kind of neuropathic pain. Those patients do really, really well. I mean, all of our patients here have done really well if they're selected well enough. In particular, I think just some of our failed back surgery patients that have had back surgery that decompress their nerves, their spinal cord, they have good, on imaging, it looks like their pathology's gone now, their spinal cord's decompressed, nose is gone, but they've been left with this new type of pain because of, whatever it could be, epidural fibrosis or just any kind of chronic post-surgical pain. Those patients tend to do really, really well, which I've seen.
Awesome.
And they've lived with it for so long, and it's like when they see us, they have really low expectations. So when they do feel better, it's really rewarding.
You touched on it a little bit, but what does make a patient qualify for the therapy? What is something that you've learned to look for?
I mean, just to qualify for the therapy, they need to have like a reduction in their pain score by 50%. Otherwise, we wouldn't even consider them. But for me personally, generally are patients that are motivated, patients that want to they have a functional goal in mind that they were at before that they now realize that they're not able to do. Patients that play sports, want to play golf, they want to play with their grandkids still, and now they realize they can't because their back hurts or they had surgery and it just wasn't exactly what they were expecting their outcome to be, and they're left with this pain that's radiating down. And it's patients that are motivated to achieve a certain goal. They're the ones that I've noticed they're the ones that do the best because they're the ones that feel the best afterwards. They're able to get back on their feet. Overall, their morbidity and mortality just decreases because they take advantage of therapy. Once their pain goes down, they're using their regainability. They're not sitting around. They're not sitting on the couch. They're up on their feet. They're doing the physical therapy. They're playing sports again. They're active. And those are the patients that, in general, do well. And that's in all of pain, not only for neuromodulation.
Yeah. How do you plan to use what you've learned?
I'm starting a job later on this year. It's in private practice. They do quite a bit of neuromodulation, PNS and SCSs. I plan on using it the same way I use it here. Select the perfect patient, implant them, make them feel better, make them be able to achieve their goals, give them their life back.
What would you say to a relative having a medical condition which could be a good indication for neuromodulation?
What would be an indication for them to have it?
Yeah, yeah.
So, I mean, this is actually happening right now. My grandpa, he's like 92 years old. He's in really good shape, except for he has really bad spinal stenosis. I don't think he's an SCS candidate, but he needed surgery. It's just like too far along now. But he had a knee replacement and is left with like medial side knee pain. And we've seen it doing like a saphenous PNS, like putting in a sprint right in their thigh. Patients after like knee surgery that are left with some kind of like chronic pain, a lot of times it is like medial sided. They do really, really well. We'll first we'll do a block there, see if the pain goes better. We already did that for him, and his pain went away, but it came back. It's, you're injecting medicine that wears off over time. So he is probably going to get it's just a temporary lead place that gets removed after 60 days. So to answer your question, I mean, would I recommend for a loved one? That is one situation which I am currently going to get one. I mean, it's a PNS for just like a knee pain that he's been having, and yeah, I think he's going to do great.
So a lot of people wouldn't correlate pumps for cancer as a form of neuromodulation. Could you tell us a little bit about how that works?
So it's different. It's not using electricity to change some kind of pain pathway to change signals throughout your nerves, but you are modulating the pain signal. You're modulating in a way that you're decreasing neurotransmitters or increasing neurotransmitters or hitting different receptors in different places to encourage either the slowing down of transmission or propagating a signal. It's chemical neuromodulation. You are using a medication that's directly going where it needs to go to modulate the signal within your nerve and in an intrathecal pump it's to your spinal cord.
Is there anything I haven't asked that you think would be important for incoming fellows or anybody who is interested in potentially pursuing practicing neuromodulation?
Incoming fellows, definitely get your hands on as many cadavers, see as many patients as you can. Just do as many as you can during fellowship, and not just like the clean ones. Make sure you run into patients that you struggle with, that afterwards either the outcome isn't what you wanted to, or you had to problem solve somehow, or you come across patients that you're like, I don't think they're a good candidate for stims, because you have to say no sometimes. So just make sure you get enough experience. That's all.